Good morning. I'm Dr. Roger Ho. I'm a psychiatrist from the National University of Singapore. Today I'm going to present my study. It's a meta-analysis of serum and CSF autoantibody in MPSLE. I have no conflict of interest to declare. Introductions. I have 3 research questions. Number 1, there are approximately 100 antibodies have been identified in SLE patients, but it remains unknown which antibody plays an important role in MPSLE. Second, CNS-reactive antibodies are present in the serum of SLE patient. Could they be potential biological markers? Third, the elevated titer of anti-virus P antibody have been associated with depressions and psychosis in SLE patients, but other studies have refuted these associations. Similar controversy exists in other antibodies. Why did I perform meta-analysis? These contradicting views require meta-analysis to assess the association between individual antibodies and MPSLE. By combining different studies to generate pool effect size, a meta-analysis can increase the power to detect the differences in the presence or absence of antibodies in MPSLE and SLE patients. The primary aim of this meta-analysis was to assess the presence of individual antibodies in the CSF and serum of MPSLE patients, as well as the manifestation of 19 specific neuropsychiatric symptoms based on the ACR criteria. We hypothesized that there will be no differences in the proportion in individual antibodies titer between MPSLE patient and SLE patients. Methodology. For the search strategy, we searched studies on antibodies in SLE and MPSLE patients systematically in the following database from inception to February 2014. The database includes PubMed, Embase, Biosis, and ScienceDirect. The following is a long list of the antibodies researched. Studies were included if they met the following criteria. The study used the standard ACR criteria to establish diagnosis of SLE. Case control study that measured blood or CSF antibody in SLE patients who did and did not suffer from MP symptoms. The presence of MP symptom was assessed clinically with standardized instrument. Study report categorically defined antibody titer, i.e. presence or absence, to allow us to calculate the effect size and pool-out ratios. We excluded pediatric SLE patients. For statistical analysis, the analysis was performed to evaluate the relationship between antibody and MPSLE if there were at least 3 studies for that antibody. The odd ratios and 95% confidence interval for the development of MPSLE in groups with positive antibody titer versus negative antibody titer were calculated. We used the random effect model because it provides more conservative results. Between study heterogeneity was assessed by the I-squared statistics. For model with considerable heterogeneity, a meta-regression was performed to identify moderator which may contribute to such heterogeneity. Result. We actually started with 1,400 research papers. We exclude around 1,300 papers. The reason was because some of the papers were not relevant to our topic. 60 papers did not meet the inclusion criteria, and 40 papers could not provide enough data for us to calculate the effect size. At the end, we recruited 41 studies in our final analysis. This table summarizes the individual MP symptoms in the 41 studies. As you can see, we have actually most of the MP symptoms except the myelinating syndrome. We only have 2 studies. Autonomic disorder, only 1. Myasthenia gravis, only 1. And pulsopathy, only 1. We found that SLE patients who are positive for serum antiphospholipid antibody are significantly associated with MPSLE. Patients with significantly associated with serum anticardiolipin antibody significantly associated with MPSLE. Patients associated with serum antineuronal antibody are significantly associated with MPSLE. And also patients who actually associated with serum positive for antiviral P antibody are significantly associated with neuropsychiatric symptoms. For specific neuropsychiatric symptoms, we started with psychiatric symptoms first. We found that mood disorder associated with serum antiviral P antibody and anti-beta-2 glycoprotein antibodies. For psychosis, it's associated with serum antiviral P antibodies. For cognitive dysfunctions, it's associated with serum antiphospholipid antibodies. For acute confusional state or delirium, it's associated with serum anticardiolipin antibodies. For CNS symptoms, for cerebrovascular diseases, it's associated with serum lupus anticoagulant, serum anticardiolipin antibodies, and antiphospholipid antibodies. For seizure disorder, it's associated with serum anticardiolipin antibodies. For peripheral nervous system symptom, we could not get adequate study for conclusion to be drawn. There were heterogeneity found in different antibodies. The source of heterogeneity, number one, is due to the diverse neuropsychiatric symptoms. Second is the age. We found that increased age actually associated with production with anticardiolipin antibody and lupus anticoagulant. And also female gender and female sex hormone may also influence the expression of antiphospholipid antibody, anticardiolipin antibodies, and antineuronal antibodies. Discussions. The summary of the findings as follows. We demonstrate that MPSLE patients more likely to develop elevated serum level of lupus anticoagulant, antiphospholipid antibody, anticardiolipin